Thank you, Bhavna. Thank you so much. First of all, congratulations on curating such an amazing course on retinoblastoma. And I would call this an A to Z of retinoblastoma. And thank you very much for having me here, Bhavna. So retinoblastoma clinical presentation and differential diagnosis is something that I'm going to speak here. I would definitely want to acknowledge all my parents, the patients of RB, and treating retinoblastoma takes a village, and this is my village. I acknowledge everyone, and I'm grateful for this journey. We all know that the global burden of retinoblastoma is 8,000 cases per year, and India and China sees around 2,000 cases per year again. And as clinicians, like we have all the distinguished speakers today are dealing with retinoblastoma, and there is a data which says that 2,000 cases per year is not seen collectively by the retinoblastoma specialists. So now the question is, where are the rest? Are they being misdiagnosed? Are they being, not really treated well? And of course, we all know that retinoblastoma can masquerade, and there is a lot of misdiagnosis, and few of them get missed in their diagnosis, and they don't reach retinoblastoma treatment center. And that's exactly why I think this topic today, I'm going to emphasize how you should never miss a retinoblastoma. Good thing about retinoblastoma is that you really don't need any fancy tools to diagnose retinoblastoma. It's purely a clinical diagnosis. With a good clinical acumen, you can definitely diagnose retinoblastoma. And we do have a natural history of intraocular retinoblastoma, starting from a small tumor, which is usually detected in a screening with a hereditary history. And of course, as the tumor evolves and progresses, there is lots of clinical presentation that I'm going to discuss. White glow is not the right glow, and that's exactly what I emphasize in my clinic, and I also emphasize this for creating public awareness. White reflex is the most common presenting symptom, and even unfortunately, due to certain socio-economic challenges and beliefs in India, even a child when presents with a white reflex, there are families that I have where the grandparents thinks that the child is born with a lucky star in the eye. They think, oh wow, this is a child, this is a special child, there is a white spot in the eye, and this is lucky for the family. So that is the height of social beliefs that we see in our society. So white reflects anything which is a white dot. It has to be examined. A detailed, dilated retina evaluation has to be done. Strabismus is yet another clinical presentation where when a child presents with strabismus with or without the white reflex, again has to be dilated and examined in detail. And why does the strabismus happen? Mostly these tumors are in the posterior pole, so there is a vision deprivation, amblyopia in these children, and the eye goes either for an ESO or an exotropia. And this is exactly this child presented with a tumor right sitting in the posterior pole. Ophthalmos, of course, when the tumor is growing and progressing, there can be glaucoma, secondary glaucoma. Two things, it could be an angle closure glaucoma where there is a large tumor which is causing a shallow angle, pushing the lens forward, or it can be a neovascular glaucoma where there is NVI, NVG. So needs attention so any child presenting with the ophthalmos, especially unilateral ophthalmos, that an intraocular tumor has to be ruled out, most commonly retinoblastoma. Another thing that you have to keep in mind is medulloepithelioma. This is a 2-year-old male child who presented with a cataract. This is a white, complete total cataract. So can retinoblastoma present as cataract? Well, it is definitely a differential diagnosis. A white reflex is definitely a differential diagnosis of cataract. Well, yes, retinoblastoma can present as a cataract. So an ultrasound B scan is the most easiest diagnostic tool. Although the child has a total cataract, something which was lurking inside was a retinoblastoma. And how does a cataract happen in a child? It could have been a large tumor which has subsequently undergone necrosis to form this small one sitting in corner with the hyperreflective spots that indicates that it is a calcified intraocular tumor in a child. It has to be retinoblastoma. Now, this child had undergone cataract extraction by a clinician, not knowing that there is a cataract sitting inside. And this slide has been, I had taken this from Dr. Santosh Honavar. This is a case that I saw during my fellowship many years back. Finally, the child, after the cataract surgery, yet the right eye was kept for cataract surgery, planned for cataract surgery, bilateral cataract, congenital cataract, and this is how it happened. After 3 months of cataract surgery, there is a mass which is coming outside. So this was indeed bilateral retinoblastoma presenting with bilateral cataract. 5-month-old baby presented as preseptal cellulitis, has gone through all clinics, has gone to higher centers thinking that it is a preseptal cellulitis, antibiotics given, no resolution, MRI taken, it is a case of bilateral retinoblastoma with the right eye, extensive tumor occupying almost more than 50% of the globe. 18 months old baby as orbital cellulitis. Similar case, child was taken into pediatric unit, treated for orbital cellulitis with antibiotics, non-resolving, and then here you see with an MRI there is a large tumor, intraocular tumor, which is extending extraocular. So orbital cellulitis or a preseptal cellulitis in a retinoblastoma is due to necrosis of the retinoblastoma. That indicates it's a very advanced tumor, and Dr. Seema has already spoken about the classification, and these fall in the group E advanced retinoblastoma. Dr. Seema has already spoken about it. You may not need to have an extensive, or a full-fledged proptosis to have a retinoblastoma, which is really bad. So there is not much of a proptosis over here. There is exotropia. The child has a cataract. There is a yellowish discoloration that you see over here. In MRI, the child has a intracranial extension. And I would say the tumor in the intracranial component is much larger than the intraocular component with the extensive optic nerve involvement. So in order to know and evaluate retinoblastoma, of course it's a clinical diagnosis, but all these children would have to undergo imaging in order to know the extent. A 10-year-old boy diagnosed as fungal uveitis, and the child has undergone, as you can see here, there is sutures over here. The child has undergone vitrectomy in order to diagnose fungal endophthalmitis and fungal uveitis with these lesions. So whenever you see these small white lesions in a pediatric patient, there are a few things that you have to keep in mind. One, of course, retinoblastoma, medulloepithelioma, even lymphoma and leukemia, before you rule out any inflammatory or infective component. What was missed? They had examined the fundus. They couldn't find a lesion, but the lesion was far away in the periphery, which is quite common in an older child presenting with retinoblastoma. And this was also missed because the ultrasound was not taken in the inferior corner. Masquerades, very common with retinoblastoma. They can present as hypopaeon, uveitis, phthisis bulbi, hyphema, and vitreous hemorrhage. Any of these presentation in a child, always rule out retinoblastoma, which is lurking inside. We have a clinical spectrum, and this is how it can progress. Now, Coats disease is one of the differential diagnosis. What is differentiating between a Coats disease and a retinoblastoma is Coats disease is mostly a leukocoria because of the exudates, and xanthocoria, sorry, I correct myself. In Coats disease, it's yellow, whereas in retinoblastoma, it is white. Xanthocoria, leukocoria. We have telangiectatic vessels in Coats disease, as you can see here, but in retinoblastoma, you have feeder vessels, where the vessels come from somewhere and just dips inside the tumor. But this, you can actually trace the vessels in Coats disease. Now, whenever this was again a case which was referred as a case of Coats disease, but look for other signs. There is a subretinal seed, there is a vitreous seed, and it can be multifocal. So this is always in favor of a retinoblastoma, but not Coats disease, although you see these vessels which is telangiectatic. Other intraocular differential diagnosis is toxocara granuloma. All these patients were referred to me as a case of retinoblastoma, toxoplasmosis, combined hamartoma, which is white in color, incontinenta pigmenti, all presented with white reflex. So basically, we need to know the anatomy of the eye and what are the structures and pathologies that can present as white reflex in a child, and this is the list of it. So diagnostic challenges, we have delay in diagnosis, we have misdiagnosis, and we have advanced diseases. So it's not difficult to diagnose retinoblastoma. These are the simple tools that you need: examination under anesthesia, 360-degree retina, 360-degree aura, and I would also add 360-degree ciliary body along with the anterior segment evaluation. Seema has already spoken about the classification, and another one is the diffuse anterior segment retinoblastoma, where the posterior pole can be absolutely normal, but the patient can present with either a nodule or these extensive lesion in the anterior chamber. So take-home message from this particular presentation of mine is retinoblastoma is a masquerader. Until and unless you're not sure in a child whether it's leukocoria, whether it's strabismus or a ophthalmos, go for a dilated intraocular examination and an imaging if it is required. Thank you so very much.
Thank you, Fairooz. That was a fascinating talk. You really covered all the different clinical presentations of retinoblastoma so beautifully. And indeed, retinoblastoma continues to surprise us, sometimes with very atypical presentations. And so any questions for Dr. Fairooz?
I have a small question. Fairooz, very nicely you have mentioned that retinoblastoma can be associated or can present with cataract.
Yes.
And though we know that it is not so common, so by ultrasonically, how do you differentiate whether it's an intraocular medullary epithelioma or it's a retinoblastoma in a patient presenting with a total cataract?
Ma'am, medullary epithelioma is an intraocular tumor which arises from the ciliary body. So obviously it will be in the periphery, and you can do a UBM where the location is very important. And another particular feature when you have these anterior segment, involvement is we call it a sago grain pattern. We know what sabudana or sago grain. So it will have this very well-defined lesions. Another thing is you have to look at the lens. There can be a coloboma of the lens. Wherever the medulloepithelioma is present in the ciliary body, at that particular area, you'll find a coloboma of lens or kind of a push of the lens in that particular area. Yeah. And at the capsule, the posterior surface of the lens, you can have these vessels which is growing. This is very, very classical of medulloepithelioma. It's not really difficult, and most of these patients present with secondary glaucoma. Yeah, so retinoblastoma doesn't have the coloboma of the lens, and they can even have a focal cataract where the tumor is, and the sheath of vessels which grows behind the posterior capsule is very, very classical of medulloepithelioma. And of course, medulloepithelioma is much less common than retinoblastoma. Thank you.